Good afternoon, everyone, and thank you for joining us today. I'm Janelle, Business Development Manager at One Heart Clinic, and we are delighted to host this 45-minute CPD session on managing heart failure in primary care. I'm delighted to be joined by our consultant cardiologist, Dr. Kaushik Guha, who will be leading today's discussion. Please feel free to drop your questions into the Q&A box as we go along. Dr. Guha will try to address them when at the end of our session. Before we get started, let me just briefly introduce our speaker. Dr. Kaushik Guha is a consultant cardiologist with extensive experience in the diagnosis and management of cardiovascular conditions, including heart failure. Today, he will be sharing his clinical experience and practical insights into managing heart failure in primary care, including diagnosis, investigation, treatment, and when to consider specialist referral. So, Dr. Guha, thank you very much for joining us today. Now, over to you.
Thank you, Janelle, for that introduction, and I thank the colleagues who have joined this call, as I appreciate it is in the midst of their busy working day. So I am Kaushik Guha. I am, as Janelle said, a consultant cardiologist in all aspects of cardiovascular disease, but have specialist expertise in heart failure and complex devices. And I'm the clinical lead for heart failure, as the slide says, at Portsmouth Hospital's University Trust from the South Coast. Terms of my conflicts of interest slide, these are as such. And I thought in our half an hour of lecture time together, we would cover a few things allied towards a condition in terms of the diagnosis, what guidance we can seek to look at how we are practicing, basics about epidemiology, and then critically, some discussion around treatments. With a hopeful time of about 30 minutes. So in terms of heart failure, when we talk about this label or we see it in our clinic letters or our coding systems on the primary care record or our computer screens, we have to be very clear what we are discussing and what we are labeling our patients with. And this is a triad in terms of the diagnosis. There is the combination of symptoms, what our patients report to us, with regards to breathlessness and fluid retention, such as edema, the position they sleep in terms of paroxysmal nocturnal dyspnea or orthopnea, the number of pillows, the signs when we examine the patient, and critically, some form of cardiac imaging. Now, the most widespread and established method of performing cardiac imaging is a transthoracic echocardiogram or anecdotally a cardiac ultrasound. And this is a real-time test. The answer is immediate and does not contain ionizing radiation and is widespread in clinical practice, both in terms of primary and secondary care. Now, when we potentially make a diagnosis of heart failure, we are very focused on the left ventricle. And the reason for that will come clearer later on in the discussion when we talk about treatment. So rather than using other nomenclature such as forward or backward, high output or low output, diastolic or systolic, or any other terminology we learnt during our resident doctor training or medical school years, we now use very standardized nomenclature, and this is a more global terminology. So heart failure with preserved ejection fraction means that the patient's left ventricle is contracting normally, but there is an issue with diastole, and the left ventricle may be thicker and stiffer, preventing the transit of blood through the heart during diastole. Heart failure with reduced ejection fraction is fairly straightforward, that the patient's systolic function has become compromised and is weakened, and an ejection fraction below 40% is used to define that class. And this again is focused on the left ventricle. And finally, we have this third group, which is scientifically debated, and this is due to the lack of evidence in the randomized control trials to date, with this group of patients with a left ventricular ejection fraction of 40 to 50%. So preserved ejection fraction is left ventricular ejection fraction of greater than 50%. Mid-range is 40 to 50%, and reduced ejection fraction is below 40%. In terms of primary care colleagues, in terms of referral pathways, we ask for very simplistic, standardized, NICE guided referral pathways. And I think most are aware, and nearly everybody has access to this blood test, which is NT-pronatriuretic peptide, or BNP, B-type natriuretic peptide. Now, whilst I talk to you, we all have circulating levels of natriuretic peptide. These form part of our regular system about maintaining body homeostasis and salt and water content, and therefore play a role within the management of blood pressure. The reason why we ask for this blood test to be performed and attached to the referral is that this helps triage our referrals into high risk and low risk groups. So in terms of the current diagnostic pathway from the NICE guidance, which was reissued last year within heart failure, the suggestion is that there should be a physical consultation, a brief examination. If there is some form of congestion, i.e. we hear crackle through a stethoscope in terms of lung changes, or we find that there is a raised venous pressure and edema, we may wish to commence a loop diuretic whilst we're making the referral simultaneously. Basic blood tests, including a full blood count to ensure the patient doesn't have concomitant anemia. Renal function and electrolytes, perhaps more pertinent in recent issues with the weather and heat waves. Liver function in terms of albumin, to ensure we're not overlooking secretive conditions such as nephrotic syndrome, and the natriuretic peptide. Certainly within the South Coast, and I've been involved with work with NHS England, there is a drive towards standardization of the referral pro forma. And in most areas of the country, this is starting to become embedded in the standard e-referral and advice and guidance systems as a digital tool and digital pathway. In terms of secondary care, what is asked of us is to look at the referrals from primary care and use all of the collective information from secondary care systems and of course, information presented by primary care colleagues, and differentiate the groups of patients into those who need to be seen and the speed at which they should be seen. Now, I appreciate there is always a disconnect between NICE guidance and real-world practice. And I appreciate that colleagues on the call may be from differing areas throughout the United Kingdom. So if the NT-proBNP is less than 400 picograms per milliliter, NICE state that this patient is unlikely to have heart failure. However, I would suggest some caveats that if the patient has significant levels of obesity or is already on an ACE inhibitor, an angiotensin II receptor blocker, or a mineralocorticoid receptor antagonist such as spironolactone, that we are just cautious about the interpretation of that number, relying all of our clinical judgment on the value by itself. If the patient has signs and symptoms and they have a reading of 400 to 2000 picograms per milliliter for an N-type pronatriuretic BNP, then it is a 6 weeks referral. And if it is greater than 2000, this is felt to be analogous to the old cancer pathways and to have the same level of seriousness attached to the referral, and therefore we are asked to see the patient within 2 weeks. Within my locality, and certainly most major secondary care trusts, this operates as a one-stop BNP clinic, i.e. the patient attends for a 12-lead ECG, echocardiogram, and consultant review with diagnosis and management plan on the same day in the same sitting. Where this has become challenging to deliver, especially in the post-pandemic world we now work in, is that the volume of referrals in many sites overwhelms whatever provision the trust can provide. So therefore, certainly locally, we struggle, like many centres do, with the 6 weeks pathway. We have to be cognizant that an NT-proBNP being raised does not equal that the patient has heart failure, but can be linked with other cardiac conditions such as atrial fibrillation, anemia, valve disease, pulmonary embolus, and therefore the referral, of course, means that the patient needs to be evaluated, but we then need to come to a formal diagnosis. And in terms of if we have proven diagnosis after clinic of heart failure, then we have two sources of information. Within England and Wales, we continue to follow NICE guidance, and the last update, as I've stated on the slide, was in September last year. For a more deeper and more robust and more clinically valuable guideline, the European Society of Cardiology update their guidance on a 5-yearly cycle. And as you can see on the slide, the new set of European Society of Cardiology guidance is due for release in the next week or two at the European Society of Cardiology Congress, which will form the latest state-of-the-art guideline for patients within Europe. Despite Brexit, we continue to be part of the European Society of Cardiology. So every specialist, when they talk to an audience of colleagues from primary care, will make a statement about the importance of their disease. We cling on to this figure of 1 million patients within the United Kingdom, which is issued by the national body, the British Society of Heart Failure, and modelled on data from 2005. However, we know that heart failure does not occur unilaterally. It can be found with other common mediators of cardiovascular disease. And if we look at our current burden of disease for other patients outside of cardiology, we can see that we have currently 6 million patients with diabetes mellitus from Diabetes UK. We have almost 7 million patients with chronic kidney disease of various stages from Kidney Care UK. And the British Heart Foundation states we have 8 million patients with cardiovascular disease. We were improving in terms of heart attack care until recent years, but we have 1.4 million survivors today of a heart attack. So all of these can feed into patients developing heart failure of any subtype. And of course, collectively, as we become more successful at making patients live to a ripe old age, they accumulate more health problems and are more at risk of developing the condition. In terms of the leading causes globally remain coronary artery disease and hypertension. Hypertension, particularly in an Afro-Caribbean population, is felt to be more malignant and more of a driver in terms of etiology. In terms of other potential etiologies, which a heart failure service will evaluate the patient for beyond the label of which subgroup the patient belongs to, potentially we may need genetic screening, and we find lots of familial issues with dilated cardiomyopathy. Of course, the patient may require valve disease. The patient may have valve disease and may require further workup and treatment allied towards valve disease. Cardio-oncology has become a growing subspecialty due to our success at cancer treatment in cancer pathways. And we know that certain types of chemotherapy, such as anthracyclines, tyrosine kinase inhibitors, and immunotherapy, can result in left ventricular issues, both currently and in the future. Though postulated to be rare, we need to have in our minds that the patient may have infiltrative disease, particularly if they have extracardiac sites of disease, such as sarcoidosis or amyloidosis. And of course, some of our patients choose to indulge in things that we may not recommend. So alcohol remains a common cause, sadly, around the United Kingdom. One of my pleas to the audience is if we do have a patient who is characterized and worked up and diagnosed, please do consider using the correct SNOMED codes on the primary care register, because this is the data that ICBs look at in terms of prevalence within the population. When we come to discussions around infrastructure in our localities, and many may report the dearth of heart failure nurse specialists, part of the reason we have a dearth of infrastructure is that we have not collectively presented our case to NHS England and the Department of Health in terms of the actual burden of disease as compared to some of the other conditions that I listed above. In terms of the basics of treating the condition, it calls for a salient, dedicated communication of a diagnosis. I appreciate primary care colleagues are constantly asked by the government and NHS England to perform consultations within 8 minutes. Clearly, there will need to be a nuanced discussion of both the diagnosis, treatment plan, and potential benefits of treatment. We've touched on the importance of coding, and like every other cardiovascular disease, treatment starts with the patient's lifestyle. There is renewed focus on cardiovascular exercise, which includes walking, swimming, a road bike, a static home bike, cross trainer, rowing machine, and the British Heart Foundation and government guidelines are stage 2 in terms of cardiovascular training. So around 70% of a patient's heart rate and up to 150 minutes a week. We should pay attention to diets, and many of our patients indulge in diets which are not healthy. And there should be attention to salt and saturated fat, increased consumption of fruits and vegetables, and some alcohol in moderation. Primary care know more about vaccination, but clearly there are a number of pieces of guidance about vaccination, about circulating viral disease. Chronic disease management, i.e. infrastructure and annualized reviews, and potentially smoking cessation for that subgroup of patients who continue to smoke. In terms of British sources of information, I signpost my patients to these groups of charities. Everyone will know the British Heart Foundation. Pumping Marvellous is the national charity for heart failure, with a gentleman who has heart failure and does not like the diagnosis. And Cardiomyopathy UK is more focused on heart muscle disease. The temptation for patients is to plug whatever is said to them by healthcare professionals into Google. I would urge some caution, because the initial websites, like many other health problems, are American, who follow different guidance to Britain and Europe. So in terms of further tips or tricks, I felt it was important perhaps to just give some extra tips to the audience. Whenever I see a new patient, particularly if they have heart failure with reduced ejection fraction, i.e. a weak left ventricle, I look at the medication I can stop. And the reason for stopping this medication is that I need the patient's blood pressure and renal function to be utilized for the evidence-based treatments, which I'll come to in the next few slides. So I always look to see if I can stop the calcium channel blocker, partly because these also potentiate peripheral edema. Alpha blockers, though may be used for benign prostatic hypertrophy for that group of patients, can lead to quite profound orthostatic hypotension and falls. And proton pump inhibitors sometimes can cause problems with hyponatremia, limiting our ability to give patients the correct combination of heart failure medication. If the patient has congestion, and particularly if they've come to our attention with breathlessness, and collectively we feel that there is some degree of pulmonary fluid, be that crackles or pleural effusions, be that clinical or be that radiographic, then I would urge everyone to start a loop diuretic. Conventional starting doses of furosemide at 20 to 40 milligrams once a day. And if the patient is already on a loop diuretic, please do feel free to increase the dose. Your patient will hospitalize if they have untreated congestion, particularly in the lungs. If we offload the patient with right heart failure, so the patient has raised venous pressure and lots of peripheral edema, as we decongest the system and improve renal blood flow, we may actually find that the eGFR starts to improve. Clearly, we have to balance our medication against the patient's total health background and comorbidities, and other health conditions do limit our ability to treat our patient optimally. These include diabetes, chronic kidney disease, potentially, and also frailty. Beware the concomitant usage of thiazide diuretics. I appreciate their role within the hypertension guidelines, but the usage of a thiazide diuretic and a loop diuretic can cause quite profound issues with hyponatremia and hypokalemia. And again, the same with mineralocorticoid receptor antagonists such as spironolactone and eplerenone. I appreciate when we are the duty HCP or duty doctor, within primary care. We are inundated potentially with blood test results. I would urge, unless the numbers are extreme, to look at the trend and to see whether there has been significant deviation in eGFR, blood pressure, or potassium before we make a knee-jerk about stopping patients' medication. Though a temporary cessation may be necessary, we have to be cognizant that all of the heart failure medication has been shown to improve quality of life, potentially improve the patient's cardiac function, reduce the cardiovascular and all-cause hospitalization, and reduce cardiovascular and all-cause mortality. So when we are taking patients' tablets away, even if there is sound grounds, then we need to have in our minds that the heart failure treatment is being down titrated, and therefore the patient is now at further risk of these issues. So, i.e., they may become more breathless, the cardiac function may deteriorate, and they are at risk of hospitalization and death. You will hear the statement in many heart failure talks about the 4 pillars of heart failure, which was coined relatively recently in 2021 by a group from Leeds. The first pillar should be ACE inhibitor, angiotensin 2 receptor blocker, or ARNI. ARNI is angiotensin 2 receptor and neprilysin inhibitor, i.e. sacubitril valsartan or Entresto. Beta blockers, the 3 that are licensed within the United Kingdom, are carvedilol, bisoprolol, and nebivolol. Mineralocorticoid receptor antagonists such as spironolactone and eplerenone, and the only 2 licensed SGLT2 inhibitors are dapagliflozin and empagliflozin. And I draw our attention, I have not filled the discussion full of Kaplan-Meier curves, but if we look at the top right curve, this is from the DAPA-HF study, published in the New England Journal of Medicine in 2019, looking at about 5,500 patients randomized to dapagliflozin or conventional heart failure therapy for heart failure with reduced ejection fraction. If one concentrates on the diagram from B or graph B, you can see that there is a very early divergence of the 2 curves. So a prescription of dapagliflozin actually reduces the patient's chances of hospitalization for heart failure after only 14 days from the prescription. And this emphasizes the need to introduce our patients early to our evidence-based therapies. For the groups of patients who have mid-range reduced ejection fraction or preserved ejection fraction, we used to inform everybody to treat comorbidities, and patients would end up on some medication for other reasons, such as hypertension, chronic kidney disease, atrial fibrillation, or diabetes mellitus. We now have randomized controlled trial evidence about the 2 classes of medication, and our patients should be considered for an SGLT2 inhibitor or mineralocorticoid receptor antagonist. And please note, this class is starting to evolve, and the latest drug, which has just got its nice health technology appraisal in the last few weeks, is finerenone. So there may be more agents within this class. For the sake of time, I will skip over these, but this is what the NICE guidelines state in terms of our algorithm of treatment for all of the classes of patients with heart failure. Moving on to cardiac devices, we have to have in our minds that in terms of a parallel discussion to our diagnosis and medical management plan, that we may need to consider our patient for an indwelling cardiac device. And broadly speaking, these have 2 roles. One is to prevent sudden cardiac death. The second is to improve left ventricular function and to be classified as a heart failure treatment. There is a third emerging class due to novel technology and digital technology and digital pathways about remote monitoring. So we have to have in our minds that a patient who has heart failure does have an increased risk compared to the general population, even if they are treated, of sudden cardiac death. And sadly, we see these stories within the national media, both within the general public and potentially celebrities, where sudden cardiac death can happen out of the blue, even if the patient was stable. We have to also have in our mind, before we talk about devices, that all of the heart failure classes of drugs have been shown to help in reducing the risk of sudden cardiac death. In terms of the heart failure treatments, again, the cornerstone of our therapies is to start with medication. And in terms of remote monitoring, beyond the need for a human being currently to be involved within the closed loop circuit to interpret the signal, the technologies are purely designed to detect occult congestions, i.e., this is retention of fluid, particularly in the patient's lungs, before they develop more manifest signs and symptoms, such as change in weight, extreme breathlessness, and crackle through a stethoscope. So in terms of our options, we may need to consider our patient for an ICD or implantable cardioverting defibrillator, which is the internal version of the external defibrillator, which many of us have either within our emergency response vehicles or our surgeries or in the community. They have two functions. One is a pacemaker function to prevent bradycardia and therefore the heart going slow. The second, which is pertinent to fast rhythms such as ventricular tachycardia and ventricular fibrillation, is the need to develop and address these rhythms initially with very rapid pacing, which is anti-tachycardia pacing or ATP, and finally a shock. There are now three types. There is the conventional type, which is transvenous, which has been around since the 1990s, subcutaneous, which has been around since the early 2010s, and extravascular, which has just become licensed in the last few years. And we have to be aware that these may be combined with a left ventricular lead or maybe a standalone device. In terms of the options, this is a transvenous device, so this is the more conventional type, which is fitted throughout the country. It's not the reason that we would perform a chest radiograph, but I draw everyone's attention to the chest radiograph, which you can now see on screen. You know that this patient has a defibrillator in situ because they have a very thick coil in the bottom of the right ventricle. And if you look at the can, there are two structures within the can. Rectangular object within the can is a capacitor which holds the charge. So therefore, we know that this patient has a single lead ICD within them, which is of transvenous type. And this is a subcutaneous type whereby the lead is not within the veins, but is actually tunneled above the sternum. So the lead exits near the axilla and the can sits inside the axillary pouch. In terms of patients, there are two groups of patients who are eligible for an ICD. Any patient who survives a cardiac arrest due to ventricular arrhythmia or has hemodynamically compromising ventricular tachycardia and has an overall life survival of greater than 1 year, i.e. they do not have serious comorbidities which prevent their survival, should be considered for an ICD at the time of hospitalization. And sadly, we have lots of these patients. Primary prevention, which is the population which is more common and more sizable, which we all see, are the group of patients who have a diagnosis of heart failure with reduced ejection fraction, an ejection fraction on cardiac imaging of below 35%. They're on maximal tolerated medical therapy, and the 12-lead ECG has a QRS restoration of less than 120 milliseconds. There are emerging issues with myocardial scar, which is visualized on a cardiac MRI study, and potentially certain genotypes which are more malignant, which may play a role in patient selection in the future, though these are all subject to large-scale randomized control studies. Moving on to the second type of treatment from a device, this is cardiac resynchronization therapy, or CRT, and relies on right-sided systems with a left ventricular lead, which is epicardial, inserted through the coronary sinus, which we access through the right atrium and right ventricular interface just next to the tricuspid valve. So this may be a biventricular pacemaker, so there may be leads in the right ventricle and on the left side, or it may be combined with a defibrillator. So the lead in the right ventricle is a defibrillator wire or lead, and there is a left ventricular lead. And these are well-proven forms of device therapy to be heart failure treatments. So they're being shown in randomized control trials in addition to medication for selected groups of patients to improve quality of life, reduce heart failure hospitalization, reduce cardiovascular mortality, and once again, potentially improve cardiac function. And this is what it looks like again on the chest radiograph. We can see that there is a right atrial lead, right ventricular lead, and if one looks just above the right ventricular lead, there is a lead that seems to be floating in midair. This is a left ventricular lead, a quadrupolar lead. You can see 4 poles on the lead, sitting within the posterolateral branch via the coronary sinus. And this is a CRTP, or biventricular pacemaker. And the reason why I've put an ECG here is that this is left bundle branch block. And one of the reasons why ECGs are important within a heart failure population and the need for attention and surveillance is that a patient may go on to develop left bundle branch block during the course of their lifetime and the course of the disease. This may be associated with disease progression and means that we should look at our patients to see if they are eligible for a biventricular system. So the patients who are eligible in terms of NICE guidance are those who are on maximal medical therapy, who have an ejection fraction below 35%, a QRS duration greater than 130 milliseconds, and classically, according to study evidence, they should preferably be in the left bundle branch block morphology, so that ECG that I've just shown you, a right bundle branch block morphology, and then there is this third class where they are termed interventricular conduction defect or conduction delay, who don't fit into the left or right bundle categories. In terms of evidence and treatment effect, the group who have left bundle branch block do the best with CRT systems. Finally, moving to remote monitoring, I appreciate this is novel and the role of these technologies being heavily evaluated both in terms of science and health economics. I've put up this slide because I've been involved with the studies to date within the United Kingdom, and this has just recently become licensed by NICE. So this is the CardioMEM system, which is a sensor implanted into the pulmonary artery. Coincidentally, you can see that this patient already has a defibrillator in situ, and the patient then lies on a transmitter, which the company hate us calling a pillow, but is a special transmitter that is designed to look like a sculpted pillow, and then generate signals which are accessed via secure databases and websites into the signal that you can see on the far right, where you get a mean, median, systolic and diastolic pulmonary artery pressure. And of course, the issues being is that over time, this becomes an individualized set of data. And if the patient starts to deviate from these parameters, then one is supposed to address this with treatment in terms of diuretics or heart failure therapy. The reason why that these therapies are being heavily discussed is clearly they seem attractive in one way in terms of infrastructure. However, in terms of conventional NHS practice, their exact role and implementation is still being heavily discussed. So to conclude, we've touched on the diagnosis of heart failure, the need to subcategorize our patients. We've covered the etiology, the drug treatments, and potential device treatments, which we may consider our patients for. I have finished there, so I am happy to take questions.
Yeah, thank you very much, Dr. Guha. That was a really informative session. If anyone has a question you would like to ask Dr. Guha directly, please feel free to raise your hand or just drop your questions into the Q&A box. Yeah, there's one question in the Q&A box, Dr. Guha.
Yeah, so I've just been asked by our colleague about COVID and long COVID, increased incidence and prevalence of heart failure. It's a very interesting question. So I think it has increased our incidence and prevalence of heart failure for many reasons. Firstly, there's the COVID effects on our healthcare infrastructure and deterioration in cardiovascular risk factors. So hypertension and diabetes mellitus and our legacy effects on all of us about how we care for our patients. Separately, there are a number of publications, including the UK. Professor Kunti's group from Leicester have published on this extensively within the Lancet, that within the first two subgroups of COVID, so if we now refer to those as alpha and beta, that there was a threefold incidence of heart failure after one COVID-19 infection. Unfortunately, the government failed to inform many of us about this, but one is absolutely correct with the question that we see many patients who have developed COVID and subsequent heart failure. So the next question that someone has just asked is how to choose between eplerenone and finerenone. Finerenone is postulated to be better than eplerenone or spironolactone via the Fine Art study, which was published recently. In terms of side effect profile, both have a similar side effect profile, and both have lower rates of gynecomastia than spironolactone. So I think at this point in time, the issue about who we consider for finerenone, personally, I would say our new patients who are coming through the system may require consideration of finerenone, but our more clinically established drug is eplerenone. So excellent question here about diet, exercise, toxins, and increase in medical cannabis. It's an interesting question. I'm not aware of any direct data about cannabis and the development of heart failure, but the person asking it is absolutely correct that we have to be somewhat cautious, especially with the compounds that contain higher rates of THC. I appreciate in the UK we have our own regulation, and it may be a subject which needs further investigation and monitoring. I know in other countries there are differing levels of THC and medical prescriptions for cannabis. So a colleague has just asked, would you encourage GPs to start heart failure treatment before formal diagnosis by the cardiologist? I would not suggest that. However, what I would suggest, and I do via my own advice and guidance in my area, is I do encourage colleagues to start a loop diuretic. I also encourage colleagues, providing there is no contraindication, to consider an SGLT2 inhibitor, especially if the patient has poorly controlled type 2 diabetes mellitus. And I may ask the colleague, depending on the situation, to consider MRA. And the reason being, as I touched on in the talk, is that these two groups are valid for all groups of patients with heart failure with preserved ejection fraction, mid-range ejection fraction, and reduced ejection fraction. Quite often when I log on to all of our collective information that we can all see, I find that the HbA1c is not at target, and SGLT2 inhibitors are second-line therapies for type 2 diabetics nowadays, as per NICE guidance. So, of course, it may invoke an opportunity whereby one can consider these. So, just to conclude on that one, I would suggest loop diuretic if there's congestion, consideration of SGLT2 inhibitor, concomitant referral, let secondary care make the triage, let us see the patient, and then potentially an MRA. But I would not necessarily endorse primary care to start the full four pillars. There may be, of course, again, other reasons to look at the patient and consider these. So the next question from a colleague is about the patient's wearable device. That's an interesting one. There's lots of debate about this, and in the US, some of these devices are now licensed by the Food and Drug Administration. I think in terms of the detection software about atrial fibrillation, that is pretty mature and is fairly decent, but I would not rely solely on someone's smart device or wearable. I would still encourage us to consider ambulatory heart monitoring or 12-lead ECGs. In terms of heart failure diagnostics embedded into the wearables, that is all coming, but is all being researched and debated as we speak. Next person has asked, can we get all four drugs for heart failure? I think it should be on board within a month, adding one at a time. So there is a publication called Strong HF For the sake of time, I did not touch on that, but that took global sites, patients with a diagnosis of heart failure with reduced ejection fraction, and if collectively, not one practitioner, but as a team, especially as a multidisciplinary team, can get the patient on all 4 drugs soon after diagnosis, particularly in the first 30 days, then the outcome for that patient is much better in terms of longevity, recovery in cardiac function, and mortality reduction. Anecdotally, to give you insight into my day-to-day practice, I have lots of patients who have hospitalized with ejection fractions of 5%. I've managed to do exactly what the person asking the question has asked, and the ejection fraction has risen after, say, 3 months to 40% or even 50%.
Do we have more questions? Oh, yes. Oh, no. Okay.
Thank you for your comments. Thank you
Yeah.
for attending.
Thank you, Dr. Guha, for taking the time to answer those questions, and thank you again for such an insightful presentation. And thank you to all of you for joining us today. We hope you found the session useful and relevant to your clinical practice. If you have a moment, we'd appreciate your feedback on today's webinar. Your feedback helps us make future sections as useful and relevant to primary care as possible. A follow-up email will be sent to you shortly. If you have any further questions, please don't hesitate to get in touch. Have a great afternoon, everyone, and we hope to see you at our next webinar. Thank you.
Thank you. Thanks.
Bye.
Bye.